Okay, so this is the restraint documentation example. Up at the top, you can see where it says to put the date and the time, and this is very important because this is the exact moment of initiation where you're going to document everything from this point forward. So you're going to want to make sure you have the correct date and time at the top. You're going to come down to Part A where it says clinical justification for use of device, and you can check all that apply. For the first three here, prevent injury to self, prevent injury to others, and combative and threatening behavior. Those are going to be used for violent restraint episodes. The second to last and the last choice, fall prevention and assess need, adaptive support, medical protective device. These two are going to be used for non-violent restraint episodes, such as the soft limb restraints, the hand mitts, the bed wraps, and the chair vest, that kind of thing. In other, you can specify specific behaviors, what the patient was doing, patient was attempting to pull out Foley catheter, etc., things like that. In Part B is the less restrictive alternatives used before restraining. Check all that apply. This is an excellent reference point for when you go to initiate restraints possibly. You might look at these less restrictive alternatives and find a behavior that you have not implemented at this time. So you might want to go back and try it, and then if it doesn't work, if it fails, you come back and obviously you're going to be implementing the restraints. But it definitely is a good reference point to take a look at periodically. Part C is the reason for use of restraint given to the patient, the family member. This is where you're documenting who you notified about education for the restraint episode. So you can let the patient know about it. Usually during the restraint episode, they're not going to be too keen on listening to you while they're being tied down. However, you can also document in the other section that you left the paperwork at the bedside for the patient to read after the episode is completed. Also, if you call a family member and you let them know their family is in restraints, but they don't answer, you want to leave, a message to have them call you back so that you can explain the situation. Part D, type of restraint, check all that apply. And this is where you're documenting which type of restraint you're using. These are the soft chests, the jerry chairs with the tray, lap buddy, etc., side rails, and has your soft limbs. We don't use the legs anymore for soft limbs. They must be used on the wrists. Cloth mitts, and you have leather restraints, which are your locked restraints, as most facilities use in current state. Here it says all patients in the locked restraints are maintained on Q15-minute observation. They are having a one-to-one with them at all times, and staff documentation will be done on the paperwork at least every hour. Episode description is whether it is the initial episode or the reassessment. If it's the initial episode, a face-to-face is being completed within an hour, and the physician will come every 8 hours from that initial episode moment in order to assess the patient while they're in locked restraints. If it is nonviolent restraints, then every 24 hours the physician will come and assess the patient. If it's a reassessment, that means that the physician for violent restraints will be every 4 hours, will give a verbal order, and again is every 24 hours for nonviolent restraints. The Part F, the observation part, is probably one of the most crucial aspects of restraint documentation. This is where you're documenting your exact time frame when you're assessing the patient. So if you start a patient in restraints at 1500, you're going to document 1500, 1600, 1700 from there. Range of motion, bathroom, and fluids should all be offered every 2 hours, and restraint relief is done with the range of motion as well. Here you're documenting the color, sensation, and movement, and that can be done via the scale down here, the key. If there are any abnormalities, you're going to want to let the doctor know immediately. Food hygiene should also be documented throughout the day. Hopefully the patient won't be in the restraints for the whole day, but some cases it is required. However, you should always be assessing. This is why we do every hour assessments, in order to with the hopes of decreasing the patient out of restraints. Comments, you can place anything as the patient ate dinner, the patient accepted nutrition, the patient pulling at restraints, and the patient's verbally abusive, anything you feel would be relevant to the restraint episode. And at the end, make sure you initial. Along with the initials, you're going to rewrite your initials down here with your full signature. At the bottom of the page, the debriefing session should be completed and documented as so. If the patient is unable to participate, you can check that off right here. However, if they are, this is an extremely important event that should occur after every restraint episode in order to assess the patient's awareness of why they ended up in restraints in the first place. For instance, you're going to be asking for staff, what could have been done to prevent the episode, what cues can help us in the future identify the patient's need for assistance quicker. And asking the patient, do you know why restraints were needed? Some patients can't remember, some patients aren't in their right state of mind, and some patients just don't believe what they did was of any concern. And this is a very important question to ask to make sure the patient is aware and to provide some excellent patient teaching at this time. You can follow up with where your needs met during the restraint episode and where you treat it with respect. The nurse can sign on the line provided, as well as any other staff members that were involved with the restraint episode and debriefing session.